So this lesson, Informed Decision Making, is where we're going to put what we've learned into practical use. When you're in labor, birth, even prenatally, you can only make the best decision with the information you have at that moment. And that's why it's so vital to be able to find out the information that you need and to know what exactly goes into an informed decision. There are 3 components of an informed decision, and that comes from a 2012 discussion paper called Communicating with Patients on Healthcare Evidence from the U.S. Institute of Medicine. We're going to go through these 3 separately, and then we'll tie it together with a really good tool. So the first component is medical evidence, which makes sense, and that's the bulk of the informed decision because you want to know what the evidence shows, right? The component 2 is clinical expertise. So what is the recommendation of your care provider? What are they good at? What's, their best tool in that situation? And then the third component is your goals and concerns. And that's how we make the decision individualized to you and your family. So component 1, medical evidence. So like I said, it makes up the bulk of the information. So that's really where you need to know where to go to find good evidence. I'm going to go through a few definitions here just because we're going to use them a lot, especially in Module 2 when we go over the evidence. So it's a good idea to know what I'm saying and what I mean when I use these definitions. So evidence-based medicine is actually a relatively new term. It was coined in the 1990s by some researchers at Mac University who, since the 80s, had been advocating for evidence-based care as opposed to care that was largely based on intuition and practice and sort of bias. So Cochrane organization was developed in 1993 as a way to compile data that had been done. So everyone knows that there are probably hundreds of studies on a certain topic. It's really hard to compile that data yourself and figure out what is actually the trend because one study might say this and another study might say this. So what the Cochrane organization does is it compiles all the data into a meta-analysis and actually comes out with a main recommendation based on whatever the review is about. So it is sort of like the best place to go if you want to find out what is the actual evidence on a certain topic, because you can really get lost in the methodology in the different studies because, again, like I said, they can say different things. So a clinical practice guideline, or a CPG, is a document written by a governing body that outlines the care its members should follow. So SOGC, which is the Society of Obstetricians and Gynecologists of Canada, and other governing bodies like the AOM, the Association of Ontario Midwives, they come together and they create documents that are based on evidence that direct the care of their providers towards their patients. So I want to spend a few minutes talking about why clinical guidelines can differ from organization to organization. So you would think that if there's evidence in Cochrane reviews on certain topics that all guidelines would say the same thing, and they don't actually. And that can be really tricky, especially if you have 2 different care providers. Say you have a midwife, but you've developed some complications and you're also involved with an OB. Their organizations can actually have very different recommendations on a certain topic. So let's go over why that can happen. 1, clinical guidelines aren't always scientific, which blow your mind. You'd think that they always need to be scientific, but they can actually include whatever they want in the guidelines. So I'm absolutely not saying that they're not scientific, but it is not a Cochrane review. A clinical guideline does not include every piece of evidence on a certain topic. They can definitely pick and choose what they want and come up with their own recommendations. The second point is a 17-year evidence to practice gap, and this always blows my mind, that it actually takes 17 years on average from something to move from evidence to practice, which is a generation essentially of care providers. And that's why we often see a lot of care that's archaic or out of practice, such as routine episiotomy. Absolutely no one should be practicing routine episiotomy. The evidence does not support it, but you actually see a lot of care providers who still use it quite frequently. Guidelines can include a level of evidence based on opinion and bias. So in a few minutes, we're going to go over the different levels of evidence, but you can have some evidence that weighs more and should weigh more than other evidence. Obviously, clinical trials should weigh more than opinion and bias, but guidelines can actually include a lot of opinion. Also, guidelines don't tell you if members of the group disagreed with the guideline or there's a conflict of interest. So they're not going to disclose that. So you can have a recommendation that you would assume represents the entire organization, and it doesn't necessarily. And also, guidelines can change without new evidence being the basis of the change. So things in culture can change, things in the medical community can change, which guide how guidelines change, but it's not actually based on new evidence. It can be just sort of based on the tide of the culture. The problem with all of this is that we come into healthcare not really knowing how to read a research study. We can all read the synopsis and think we've got a handle on the content, but it's much more complicated than that. And I won't go into how to read a research study here, but I have included an article in the resource section of this lesson that goes a little bit deeper into how to read a research study if that's something you want to pursue on your own. But I do want to mention that there's different levels of evidence, and you should keep this in mind when reading a clinical guideline. For now, I want to take us to the SOGC clinical guideline on VBAC, or trial of labor after cesarean. I want to just go through the recommendations really quickly without even going into the evidence yet to show what the recommendations are, and then we're going to go back after and look at how the weight of the research actually kind of changes the weight of the recommendations. Okay, so here's that recommendation or the clinical guideline from the SOGC. So it's number 382. And it was published in, here we got July 2019. So I'm going to just scroll down to the recommendations. So again, this is for VBAC. So this is women who have had a C-section and they're planning a vaginal birth. So I want to go to just a few of them. So provided there are no contraindications, a trial of labor after cesarean should be offered to all women with one previous low segment transverse cesarean. And this discussion should be documented. And then you see in brackets 2B. We're going to go over that in a minute. But anyways, essentially that if there's no contraindications, everyone should be offered a VBAC. Women with one prior low transverse cesarean section should be informed that baseline risk of uterine rupture with trial of labor after C-section is 0.47%. Women should be informed that most other maternal complications are not significantly different between elective C-section and trial of labor. There are limited studies reporting on outcomes of women with more than 2 prior C-sections. So often when women have 2 C-sections, they're really discouraged from trying to have a VBAC. It is not an absolute contraindication for women with a breech presentation to undergo a trial of labor after C-section. However, women should be advised that there is insufficient information to assess risks of trial of labor. This number 26. The entire team should be made aware of the presence of a woman undergoing a trial of labor after C-section laboring. So just letting everyone know that you've got a VBAC. To optimize maternal neonatal outcomes, a woman having a trial of labor after C-section should be cared for in a hospital that has resources to perform an emergency C-section. The woman and her healthcare provider should be aware of the availability of obstetric, anesthesia, pediatric, operating room staff in the setting where she chooses to give birth. So that's often why they discourage VBAC at home. So you're probably wondering why I just went through that with you, but I'm going to explain that now. So different studies, or all studies, have levels and grades of evidence, and this is something that's systematic, it's global, so that people can look at a study and look at the level and the grade, and then they know what that means. So I'm going to quickly go over that because that's really going to change the weight of some of those recommendations I just went through, okay? So the level lets us know what type of study or research was conducted to get a certain result. So gold standard in all research is a random controlled trial. So that would be level 1. So you've got at least one RCT with proper randomization. And you can't always get that, especially in maternal health care. You can't just, especially if you kind of know that something might be a negative outcome, you can't just randomize women to that, knowing that there might be a bad outcome. So sometimes you don't get that, but that's a level 1. And then you go level 2 and then level 3. And level 3 is expert opinion. So that's the levels. And then you have our grades. And grades are sort of, typical like you would get in school. A being that that means the research is high. And further research is unlikely to change our confidence in the research. And then grade D is very low, and that any estimate effect is very uncertain, meaning that the research is really not good quality. So I want to go back to the trial of labor guideline so you can see how knowing and understanding those levels really impacts the weight of the evidence. So we're back here at the guideline. Let's go back over those recommendations now that we know what those numbers and brackets mean and see what we think of it now. So we'll scroll down to the first one. Provided there are no contraindications, a trial of labor after cesarean should be offered to all women with one previous low segment cesarean, and then discussion should be documented. In brackets, you can see 2-2, which is the time series comparison or dramatic results from uncontrolled studies, and then the B is the grade. So it's not a random controlled trial. It's well-designed study. So that's good. It's better than a 3, but it's definitely not a random control trial. But, we know that all women should be offered a VBAC unless they have any major contraindications. Number 5, women with one prior low transverse C-section should be informed that the baseline risk of rupture is 0.47%. And that one's based on time series comparisons of dramatic results from uncontrolled studies. So again, not a random control, but if you have women who are in a study, you can't randomly assign them to a VBAC if they absolutely don't want that risk. So that's why you don't have an RCT, but it's grade A, so that's pretty good. And we know that that's about the rate of a rupture, so that's pretty evidence-based. Number 6, women should be informed that most other maternal complications are not significantly different between elective C-section and a VBAC. And that's, again, level 2-2B, which is the time series comparison. So again, that's pretty good, and I think that's the best we're going to get in this recommendation, because again, you can't randomize women to VBAC if they absolutely don't want it. And then we'll jump down to 14, limited studies reporting on outcomes of women with more than 2 prior C-sections. So again, that recommendation that women who have 2 C-sections don't try VBAC, and this is one, and this is based on a random controlled trial, meaning that evidence that we just don't have. And then we went to number 15. It is not an absolute contraindication for women with breech presentation to undergo a trial of labor, but they should be advisors insufficient information. And then you see 3B. And that's the first one we see that's actually based on expert opinion. There isn't a lot of research, but women are sort of dissuaded from doing VBAC if they have a breech presentation. And then we went down to number 26. Entire team should be made aware of the presence of a woman undergoing a trial of labor after C-section, and that's 3A. And again, look at that. That's based on expert opinion. So it's the opinion of the OBs, doctors who made this guideline, that everyone should be made aware, which, seems reasonable. But also, if you're in the hospital, the OB and the anesthesia team is on call. They're ready for anyone because you could walk off the street needing surgery. So it shouldn't really make a difference to how quick they can do a C-section. 29, to optimize maternal neonatal outcomes, women having a trial of labor after a C-section should be cared for in a hospital that has resources to perform an emergency C-section. And again, this recommendation is really big on recommending women deliver in hospital when they're planning a VBAC, but it's actually based on expert opinion. It's not based on evidence from studies that show that it's unsafe to be at home. And in our module 3, when we actually talk about VBAC, we're going to dig into this one a little bit deeper because it has pretty big implications. And then 30, the women or healthcare provider should be made aware of the availability of all the team and people that would help in the setting where she chooses to give birth. Essentially saying if you're at home, you don't have any of these people, again, based on expert opinion. The thing is that care providers don't go over any of this with us, and I didn't really either, to explain what the levels are. We just kind of state what the recommendation is without talking about the evidence behind it. We don't have time in our visits to go over this, which is why it's really important for you to do your research at home and to look at what the evidence says. The moral of the story is that you should understand that the term evidence or research can be really loaded, and you might really need to dig deep to understand the quality of the information the care provider is giving you. So the next component of an informed decision is clinical expertise, and this includes the provider's experience, intuition, and confidence. Another definition I want to go over is availability bias. And this is something we all encounter, but we probably don't see it as like a definition in something that's very systemic. So availability bias is when an example of a situation comes to the provider's mind and seems more representative of a situation than is actually the case. And this happens when there are bad outcomes. So, when someone at home who was planning a VBAC ruptured, that meant that everyone stopped doing VBAC at home because it was dangerous. Or your doctor doesn't want to do a certain intervention because once they had a baby die. And that's what availability bias is. I do want you to keep in mind when we talk about clinical expertise that obstetrics is very litigious, and be aware of how it affects the decisions of your care provider. So OBs have the highest liability insurance of all physicians because when they are sued, if there's a negative outcome, essentially the money won has to cover potentially a lifelong disability in a baby. So their liability insurance is really expensive, and they're most likely to be sued of all negative outcomes in healthcare, more so in the States than Canada. But that can really cloud and affect the way they make decisions. So I really want to get you to keep that in mind. The third and final component is patient goals and concerns. And this is where your individuality comes into play, and the part of the decision that's uniquely yours. And this is where your provider can't really make a decision for you. You want to make sure that you and your support team discuss your goals and concerns before you're in labor so that you are on the same page with your support people, because you really don't want to be figuring all that out in labor. So now that I've discussed in detail the components of informed decision, I'm going to share this really great tool that I've discovered. It's really going to simplify making decisions, and it's a step-by-step process. It's called a brain decision-making tool. And it's going to include the three components: the medical evidence, clinical expertise, and your goals. And it allows you to break down every decision in a moment to make sure that you have the information to make a good decision. So BRAIN stands for benefits, risks, alternatives, intuition, and nothing. And nothing is, what if we do nothing? Because sometimes all you need is time for things to change. So benefits are, what are the benefits of the course of action? And then you want to consider that for you and your baby. What are the risks? Obviously, that one's pretty obvious. What are potential bad outcomes? What are alternatives? What are other things that we could try? Intuition, that's a big one. What does your gut tell you? And what if you do nothing? And that's a big one for, especially when you're considering C-section for failure to progress or long induction, things like that. So you don't need to print this, but I have included it as a PDF in the resource section because I think it's a really good tool. Again, you don't need to print it out to remember how to do it. The BRAIN acronym makes it really simple. But for those of you that want to print it out and then use it, it might not be a bad idea to practice this process. So that said, you're in a situation, something comes up, and you decide to use the BRAIN decision tool. And again, you don't need to make it official. You don't need to pull up paper. You don't even need to tell your doctor doing it. You just ask what the benefits are. What are the risks? What are other things we can do? And then think about your intuition, and then ask what if you do nothing. But here are some things that you can ask if you need more information. Again, some of this will be obvious to you, but here are some examples of ways to dig a little bit deeper. It can be uncomfortable to ask these questions, but only, again, because we've been brought up not to question healthcare providers. And you can collect more information while staying respectful and appreciative of the roles as your care provider. So things like, I'm not sure I understand. Can you explain it in more detail? What would happen to the baby if I do that? What if I don't? I would feel more comfortable with a second opinion. What are other options? Is there another alternative? What if I wait? Can you print off the research that supports that recommendation? I think I'd like to read it for myself. Where can I get more information on that? We need more time to decide. And this is some research that I found. Can I show you? And that's where your prenatal prep binder will come in really handy. So guys, I really hope that you have found this lesson helpful. The goal was to compile the rest of the lessons that we'd already gone through into practical skills. So now you can make good decisions, knowing benefits, risks, alternatives. What does your intuition or your gut say? And what if we do nothing?